Okay, so just to recapitulate the last things that we talked about, okay? So we talked about the hyposecretion of cortisol and Addison's disease. And what we said is that we were going to look into the steroids that are regulating the zona glomerulosa with mineralocorticoids, which are important in aldosterone. Okay, so these ones are the mineralocorticoids that regulates the salt balance, electrolyte balance, and they are produced by the zona glomerulosa. Okay, I'm gonna skip quick because it jumped on the other video. Okay, now why is this important? Because the mineralocorticoids impact on the kidney to regulate the absorption of water and sodium. So they are very, very important for electrolyte balance. Okay, and if untreated can lead to death. Okay, this tied up with the system that we studied back in the first sessions on lecture number 17 and 18 on the aldosterone system and its impacts on the angiotensin. Here we have the two pathways. We have the in blue the ACTH, right, pituitary, hypothalamus, pituitary, ACTH, adrenal axis that activates aldosterone, and aldosterone in turn affects the kidney with the excretion of sodium, excretion of water, and intake of potassium. So it results also in less potassium in the blood, and this potassium in the blood feedbacks negatively in the adrenal cortex. But this works in parallel with the angiotensin system. The angiotensin system comes from renin produced from the kidney that impacts on the angiotensinogen of the liver and also the lung and creates angiotensin 2, which will further impact in the adrenal gland and again have an impact on electrolyte balance. Okay, so the three pathways stimulate the glomerulosa and the cell synthesis of aldosterone, and the renin angiosystem is in green, major controlling factor. ACTH is also important here in blue, and it leads to increased plasma potassium in red. Okay? The secretion of aldosterone is also directly stimulated by trauma, anxiety, hyperkalemia, and hypernatremia, and inhibited by atrial natriuretic peptide NP. So here is, just to summarize, the pathway itself of the renin angiotensin aldosterone system, which they are all linked together. We studied this in the past and is in your past lecture, so you need to go back to the lecture, okay? But basically, the renin system starts with the kidney that produces renin, liver produces angiotensinogen, and basically converts it into angiotensin 1, which is further modified into angiotensin 2. Angiotensin 2 has multiple physiological functions, but the primary you can see in blue means with arrow, blue arrow, a stimulatory effect. So has an increase in the sympathetic activity of the nervous system. It has a positive effect of tubular sodium and chloride reabsorption and calcium excretion on the water. So the electrolyte balance in the blood very important, right? Also, this is further modulated by the adrenal cortex through aldosterone here, right? So the angiotensin and aldosterone makes the same effect, right? They all both work in the secretion and absorption of sodium in the in this system. Also, we have the anterior vasoconstriction and obviously blood pressure, and also it affects through angiotensin the production of ADH or antidiuretic hormone, which also has an effect on balance. So the net effect, right, is the water and salt retention and water balance in the blood. So very, very important. So etiologies which are caused by primary hyperaldosteronism. Adrenal adenoma, as we said, which are called also Cone syndrome, and adrenal adenoma, obviously, it was first described by Dr. Jerome Combe, and if you think about an adenoma growing in the zona glomerulosa, what it will do is to produce too much aldosterone. That's why it's called primary hyper, which is more aldosteronism. Okay, this is the major cause, and it affects the accounts for 80% of all the cases of hyper aldosteronism. So 80% of them are caused by these tumors of adrenal adenoma. Okay, then also these adenomas can be unilateral and solitary, so there is only one adenoma in one of the adrenal glands. So obviously this can be lead to adrenalectomy of one side. Also, we can have hyperaldosteronism when there is adrenal hyperplasia, i.e., example, the zona glomerulosa grows in a way which is too big, right? Hyperplasia. If we have, this can be unilateral or bilateral adrenal hyperplasia, and then there are too many cells that produces mineralocorticoids or aldosterone, resulting obviously in excessive secretion of aldosterone. And these account for 15% of all cases of hyperaldosteronism. There is also a much rarer recognized form of unilateral adrenal hyperplasia, which is treated with adrenalectomy. Okay? So, again, etiologies of the primary hyperaldosteronism can be familial, so basically genetic, and was first described by Sunderland. There are two forms of familiar forms, right? The type 1 of hyperaldosteronism, which is glucocorticoid remediable aldosteronism, GRA, and the type 2, which is inherited aldosterone producing adenoma. So there are adenomas that run in families and are inherited. Okay, so the form of GRA is produced because there is an abnormal 11 hydroxylase genes that basically binds to the aldosterone synthase. What happens is that this enzyme is abnormal and makes the ACTH release to a stimulation of abnormal chimera and excessive aldosterone production. In now, the aldosterone is produced by the zona fasciculata rather than the zona glomerulosa, which makes a lot more aldosterone. So that's why is hyperaldosteronism. So the pattern of inheritance of this genetic, because remember they are familial. Familial means that is genetics, is hyperaldosteronism, familial, right? And is autosomal dominant, right? So that means that only one copy is dominant, right? You don't, recessive means that you need two copies abnormal of this gene, but in this case is autosomal dominant. Okay, also much rarer, it can produce by adrenal carcinomas. So what are adrenal carcinomas is a metastatic or cancer that arise in the aldosterone producing cells, and there are very rare cause of primary hyperaldosteronism. So what are the consequences of primary aldosteronism? Obviously, if you think about the cells in the glomerulosa produces too much aldosterone. So there is excessive aldosterone production acting at the distal renal tubule promoting sodium retention. Obviously, this causes water imbalance and electrolyte imbalance and produces volume expansions with hypertension on the cardiovascular system. This is also accompanied by excretion of potassium, resulting in hypokalemia. Okay, very important. So, what are the consequences of primary hyperaldosteronism? Right? They are that we have aldosteronism, right? And there is too secretion of potassium, so there are metabolic alkalosis that produces muscle weakness. But here in red, we have the connection with the renin angiotensin aldosterone system. There is plasma volume increase, then obviously plasma volume increase produces hypertension, hypernatremia, and sodium reabsorption, and this is obviously an effect of aldosteronism. Okay, so it affects at both levels. So again, what we have here is the renin angiotensin aldosterone system. This was to you taught in the class of lecture number, I think it was 17, 18, right, on the adrenal glands and adrenal cortex. So it's important for you to know the mechanism of angiotensin 1 and how it affects the multiple physiological functions, right? So in terms of clinical features, okay, primary hyperaldosteronism, clinical features, resistant, unresponsive to treatment, okay, hypertension due to increased water and sodium retention, hypokalemia, usually less than 3.5 nanomole per liter, although 70% of the patient may be normocalenemic, okay? So hypokalemia is really important in this condition. Obviously, they have metabolic alkalosis. Sodium may be normal or at the high level end to normal. They produce polyuria, nocturia, and polydipsia due to the reduced ability of the kidney to concentrate urine. So there are problems in urinated, right? Polydipsia, which is a lot of urination. Weakness in the muscles. Obviously, why weakness in the muscles? Due to hypokalemia, right? This is very important and it affects the muscles. Also, very severe lethargy and also headaches and cardiac arrhythmias because it's very important in the cardiac arrhythmia. So, hyperaldosteronism has also been linked to hypertension. Okay, so for more than 30 years, clinicians had thought primary hyperaldosteronism to be a rare form of hypertension. It is now recognized to be the most common form of secondary hypertension. Using the plasma aldosterone to plasma renin activity rate, we can basically ratio as a case finding test following by aldosterone suppression confirmation testing has resulted in much higher prevalence of 5 to 13% with hypertension have a problem in the renin aldosterone system. Okay, important to have this in mind. So what are the conditions of the adrenal gland causes? Why or other conditions of the adrenal gland causes hypertension? Okay, so if you think about regulation the blood pressure is equal to the cardiac output multiplied by the TPR. Okay, TPR is the total peripheral resistance, a measure of the degree of constriction of the arterioles, right? So stroke volume regulated by ventricles and the heart also by the SI node. Okay, so basically this is regulated by the hyperaldosterone renin system. So the investigations for clinics, right, are basically shows of hypokalemia and hypernatremia, okay? Also, renin and aldosterone spot obviously abnormalities in renin and aldosterone levels. Aldosterone levels are rise and renin should be low. If renin is high or normal, it is virtually excluded diagnosis of primary hyperaldosteronism. Patients should not be on any hypertensive drug that may interfere with plasma renin activity and aldosterone. So it's very important not to be in any of these drugs. If treatment is necessary while the above tests are carried out, then they need beta blockers usage. Also may show arrhythmias, so a ECG, right, to look for arrhythmias and electrolyte imbalance. Also, CT or MRI scans are important, can be used to locate the adrenal adenoma and may also pick up hyperplasia, okay? Other imaging techniques can be used also, like for example CT scans, and to see if there is a adenoma in the adrenal gland. Also, selective adrenal venous samples. This is a gold standard for localizing cause of primary hyperaldosteronism. And in the cases of familiar or genetics, what is used is available, obviously, genes that are important. Okay, so there is a panel of genes affected in mutations for GRA. Obviously, you don't need to know this by heart, it's just some information on the patients when they are treated. But basically, for the diagnosis purposes, aldosterone renin ratio is called ARR and can be used as a screening for primary hyperaldosteronism. Patients with hypertension and hypokalemia or resistant to hypertension should be screened. If the ratio is bigger than 800, the patient should be investigated further for imaging located the source. Okay? Isolated aldosterone levels are used sometimes to improve specificity. So if aldosterone is more elevated than 1000 with a raised aldosterone renin ratio, there is 90% specificity. This method is better for Afro-Caribbean patients as they tend to have a low renin levels. Also, there needs to be care of antihypertensive medications. So obviously, some people maybe take beta blockers can be used and give false positive, diuretics, AC inhibitors, and also calcium channel blockers can give you, because they work in the kidney, a false positive. Okay, so ARR reference ranges. Okay, so for cons, okay, unlikely aldosterone renin ratio less than 800. Possible cons, aldosterone renin ratio greater than 1000. Cons very likely is when aldosterone renin ratio is greater than 2000. Now, this is just for your information. You don't need to know for the exam. This is too much. But just to have as your information, because those are the guidelines for a diagnosis. So this one is what we have here for the range for plasma aldosterone. This varies plasma aldosterone in children, teens, in adults because they have several requirements. Obviously, the aldosterone is in the standing and lying down, and this is the different concentration that we have for children, teens, and adults, and you can see that it varies into two stages. If you want more information, there is a web page where you can see the concentrations and the explanation of why there is this test. Other diagnostic methods, obviously the lying and standing IRR is important, right? Aldosterone is affected by upright posture, okay? Therefore, samples are taken lying down and then repeated after being upright for few hours. In primary hyperaldosteronism, the plasma aldosterone increases after 4 hours of standing up, usually by more than 30%. No change in the aldosterone-renin ratio with posture in the presence of adrenal adenoma, right? Because the adrenal adenoma will still secrete, so it would override the ratio of normal ARR. Only guideline results needs to be interpreted with caution. Also, sol loading and ARR levels can be used to further confirmation of primary aldosteronism, although not very often used. Patient is loaded with sol, high sodium diet, and slow release sodium tablets for 2 weeks before samples are taken. Salt should suppress plasma aldosterone, ARR, cortisol, and bicarbonate levels are measured. Okay? Failure to suppress aldosterone confirms a primary hyperaldosteronism. So, different diagnoses of hyperaldosteronism, differential diagnosis of hyper with low renin, primary hyperaldosteronism, adenoma, right, BAH, GRI, or carcinoma, or also congenital adrenal hyperplasia. Differential diagnosis of hyperaldosteronism with high renin, renal artery stenosis, renin secretion tumors, because we can have tumors that express too much renin and affect the renin angiotensin and obviously the sodium, potassium retention electrolyte balance, congestive cardiac failure, nephrotic syndrome, and diuretic use. Cushing's disease may also present with hypertension and hypokalemia, but both the aldosterone and the renin levels are low. Okay, so diagnosis summary of the disease. In primary hyperaldosteronism, aldosterone is high, renin is low, cortisol is normal. In secondary hyperaldosteronism is high, renin normal. Cushing's syndrome, aldosterone is low, renin is low, cortisol is high. In adrenal insufficiency or Addison's disease, aldosterone is low, renin is high, and cortisol is low. So how is the treatment of Con's syndrome? The definite treatment and the first line of treatment is always surgery. Medical management is used before the surgery. So there are aldosterone antagonists such as spironolactone, which is a drug which is an antagonist of aldosterone. Surgical treatment involves adrenalectomy. An adrenalectomy means excision of the entire adrenal gland. Now, this is done by laparoscopic surgery, and basically it's safe and may be better than open surgery. Hypertension may persist after removal of the adenoma, and patients may require lifelong antihypertensive treatment. Now, secondary hyperaldosteronism. Increased aldosterone secretion in response to increased level angiotensin due to increased secretion of renin from juxtaglomerular cells. Physiological reflex is designed to conserve sodium under conditions such as the hemorrhage or salt and water depletion. And this can have, for example, physiological reflex in diarrhea and vomiting, right? So there is a depletion of calcium and sodium, okay? Commonest cause of diuretic therapy. Other causes include congestive heart failure, hepatic failure, and nephrotic syndrome. So, pseudo hyperaldosteronism, apparent mineralocorticoid excess. Symptoms of hyperaldosteronism: bad plasma levels of aldosterone, angiotensin II, and plasma renal activity all normal or suppressed, caused by hyperactivation of MR by cortisol, right? Rather than aldosterone. Very important, okay? Because if you have hyperactivation, right, of cortisol can produce some of the above symptoms. Pseudo hyperaldosteronism. Three possible causes. For example, decrease in 11 alpha beta HD2 expression, so mutations in the promoter or less mRNA. Also, there is possibility that the alpha beta HSD2 activity compromise, loss of function mutations in this gene, okay? And activity overwhelm, like for example, if there is too overwhelmed, Cushing's disease and syndrome. Remember, what does 11-HSD2 do, right? And this is for you to look, because we did this lecture on the pathways, and you should be able to relate the pathway to the different functions of the aldosterone and system, okay? Now we're gonna look into abnormality of the medulla. Remember, this is the adrenal gland. We can see here the cortex, and this is the medulla. And now what you can see here is a big tumor growing in the medulla, which is called pheochromocytomas. Okay, but remember, this you need to study in parallel with the medulla. When you study the medulla, you study also the disease, right? The medulla comes from the nervous parasympathetic system, right? And remember, the adrenal is formed of the adrenal cortex and the adrenal medulla. And apart from the cortex, which we know very well, with the three zones, zona glomerulosa, fasciculata, there is the adrenal medulla. Cortex and medulla differ very much in origin and structure and function. Remember that the adrenal medulla comes from the neural crest, okay? And the neural crest cells migrate into here. So they have neuronal, okay? The medulla derived from the neural crest cells in the ectoderm, okay? So tumors are not now here on the adrenal, which affects zona glomerulosa fasciculata. These pheochromocytomas, right, are in the medulla. And the medulla, if you remember, secretes catecholamines, adrenaline, and neuroadrenaline. Okay? So the pheochromocytomas are neuroendocrine tumors of the adrenal medulla. The adrenomedullary, remember, adrenomedullary chromaffin cells are in the middle, and they hypersecrete catecholamines, which are noradrenaline and adrenaline. Imagine that you have a tumor that is oversecreting adrenaline. You will be very stressed, and because adrenaline controls the fight for flight mode of stress, okay? Also, catecholamines increases cardiac output, so there is a very sensitive and important function that if there is a tumor of a pheochromocytoma that is untreated can lead to heart attacks, okay? Because there is too much adrenaline being produced from the medulla, okay? Perfect. So also it affects vasoconstriction through the adrenoceptors. And remember, we studied that in the lecture. So very, very rare, very important tumors that needs to be operated through adrenalectomy, okay? So hormones of the adrenal medulla, right? We know them, and just as a brief, remember, is epinephrine, norepinephrine, and dopamine, okay? So there are synthesis and secretions of chromaffin cells, and responses for the fight or flight response affect very much the heart rate, the blood pressure, and visceral smooth muscles. And these tumors arise from these chromaffin cells, okay, and form the pheochromocytomas, okay. So with this, we're not gonna go through these questions, but I wanted just to go to the last part. These questions will be given to you later, but we're gonna go in the last part of the lecture, which is a type of adrenogenital syndromes, okay? Why adrenogenital syndromes? Remember that the cortex also secretes sexual hormones, right? And these ones are known as congenital adrenal hyperplasia, okay? It affects 1 in 5,000 birds. This is the prevalence of congenital adrenal hyperplasia, right? And they are considered congenital syndromes. Is a group of autosomal recessive, right? See, what do you know? What is autosomal recessive or autosomal dominant, right? This is autosomal recessive disorder of cortisol biosynthesis because there are mutations or abnormal on the 21 alpha hydroxylase deficiency. Go back to the pathways of the hydroxylases. Is the cause of 90% of the causes and is characterized by cortisol deficiency with or without aldosterone deficiency and, very important, androgen excess. The second most common cause is deficient in the 11 hydroxylase. The symptoms are that female infants have ambiguous genitalia, so have genitalia that looks like penis, and male don't have signs at birth except subtle hyperpigmentation and penile enlargement. And here are two examples of congenital adrenal hyperplasia. So the adrenal has hyperplasia of lack of this enzyme functioning, so there is no production of the cortisol, but then the pathway is switched to produce androgens. So as you can see here, there is ambiguous formation of the female, instead of female, is a virilized ambiguous genitalia. Very important to detect this and very important condition. Obviously, if you look at the whole the pathway, it will make sense, right? Because what happens is that in this condition, we don't have the 24 hydroxylase, so no mineralocorticoids are produced. We don't have these enzymes, so no glucocorticoids. So the pathway is shift towards the dehydroepiandrosterone, right? To this level, the DHA, okay? So there is no less cholesterol, so the pathway is switched to this level. There is too much production of the in the zona reticularis of the hydroepiandrosterone and obviously production of androestenoids and then increase of testosterone, right, which will form at the end a virilized sexual organ because it will increase the levels of androgens. Okay, very important. So obviously we already touched on this and the gene of steroidogenic enzymes and the P400 oxidases that was also in the other lecture. But basically what we can say is that in the congenital adrenal hypoplasia, what you need to understand is that the enzymes do not work well. So there are less of this, right, enzyme function, and basically mineralocorticoid less. There is more in these enzymes, okay, and then also less in the lipoid chain, and then obviously what it results not having the 21 function hydroxylase, right, or the 11 hydroxylase. What happens is that produces CAH by increasing the level of androgens, right? CAH is congenital adrenal hyperplasia. Okay? So remember that the pathways that you studied with the different production starting from cholesterol, going to aldosterone, going to cortisol, going to androgen, when there are deficits in the different enzymes, it can lead to increase in androgen production. Okay? So just to finish, we're going to talk about the congenital adrenal hypoplasia, which is the last form, which is lipoid. So basically fails to make any steroid hormone in this condition, and basically there is accumulation of large lipid droplets, and obviously these ones are cholesterol esters and adrenocortical cells. Could arise due to loss of function of mutations in genes, remember, of the STAR, TSP, and the side cleavage gene enzyme, which we studied in lecture number 18 and 19, right? That we were studying the steroidogenic uh, cascade and pathway. So those are enzymes which are very important on the production of the corticoid and the hormone steroid hormones, okay, in the mitochondria. So with this, okay, we have finished the lecture. We have here several questions which I have put in your PDF, most of them without the answers for you to revise, okay? But I will be posting the right answers at the end of this week. This is simply for you to rehearse and to understand whether you have understood the lectures, and is for your own understanding, okay? So let me then pause. Okay, we have the video here, and stop sharing. I need to go to Camtasia. Okay, guys, it's been a little bit more complicated today. Take it easy. Study the simple disease. You don't need to know everything, but the main disease and the main diagnosis. Okay. Thank you very much for attending the class. And I should be able to see you soon because I'm going to be giving you the class which is very close to me on the reproduction. Okay, and with that I will be finishing. Thank you very much, and I will speak to you later. Thank you.